Thank you, Eddie. Welcome back. And please keep your mobile phones on silent. So we'll have 5 abstract-driven presentations now. We'll start off with Morubula, who would be talking on the hepatitis C laboratory data analysis on patients seeking medical attention in a public health sector in South Africa. You have the floor.
Good afternoon, ladies and gentlemen. The presentation is not the correct one. It was there and so it moved. Okay, thank you. Okay, my name is Morubula Manamela from the National Institute for Communicable Diseases. I'm in the Center for Vaccine and Immunology, and we are doing research for viral hepatitis. Today I'm going to present the data for viral hepatitis that we got from the laboratory, which is hepatitis laboratory data for patients seeking medical attention in the public health sector in South Africa, which was collected from 2017 to 2021. As Andrew mentioned earlier during the presentation, in South Africa, the hepatitis C prevalence differs depending on the population that you are looking at, and is lower in general population compared to the high-risk population, which is the key population for hepatitis C. So, in South Africa, hepatitis C and other viral hepatitis A to E are notifiable medical conditions. And currently the data is collected through the notifiable medical system that is also managed at NICD in collaboration with the National Department of Health. And the surveillance is a passive surveillance where laboratories and healthcare facilities are reporting to the NMC, and the data is collated and analyzed to check the different prevalences for the viral hepatitis and other diseases that are notifiable. Looking at the NMC, we noticed that the NMC is underreporting for hepatitis C virus. And then we decided to look at the National Health Laboratory data, which we thought it would be a better source of data to monitor prevalence. And we also looked at analyzing the laboratory tests for laboratory testing patterns, and also look at the circulating genotypes. So as I mentioned, the source of data for this study was the NHLS laboratory data from public health care services. The National Health Laboratory Service offers service to estimated 85% of the population in the country. And the data management that we did was to extract the data from the National Health Laboratory Service Central Data Warehouse and deduplicate it to one patient. And the deduplication, what we did was looking at the patient demographic data, and we also matched it, and after matching we did a probability testing with a cutoff of 75% match, just to increase the sensitivity of our matching and to improve the quality of our matching to have a single information aligned for one patient. I'm sorry that green color is not really visible. The data that we got, we excluded all data that looked like the laboratory quality assurance data, and we also excluded the HCV studies which were coded not as that we can't match, but the others like I know in Pretoria, they also have certain studies where they enroll patients with their names and everything. We didn't exclude those ones. And that kind of data that we have, we looked at how we are going to analyze it, and then we used the WHO guideline for testing, which was published in 2016, to classify the data as those patients with antibody positive results that are positive. We regarded them as hepatitis C exposed patients, and those which were followed with hepatitis C virals, nucleic acid, and they are positive, we classified them as current infection, and the ones that the nucleic acid test was negative as past infection, and the ones that were tested with antibody positive and there was no reactive results, they were classified as no exposure to hepatitis C virus. So looking at the results, we did look at the laboratory seroprevalence, which was, we started by looking at the antibody positivity rate when the laboratory were testing for the HCV viruses. And then we saw a pattern where the positivity rate was just above 2%, except in 2018 where it was 1.86%. And looking at the prevalence per 100,000, the same pattern looked, it looked like the same pattern where only 2018 was below with 4 per 100,000, but other years were consistently showing 5 per 100,000, which showed that in South Africa, basically the prevalence is not changing. We looked at this data, tried to disaggregate a little bit to see what is happening with the data, and what we found out is that there was an increase in Gauteng province from 3.58 to 5.2% over those 5-year period. And we saw that Mpumalanga also show a little bit of increase, and the laboratory positivity rate for Limpopo looks like it was decreasing. For other provinces, you can see it just doesn't show if it's increasing or not increasing. And then if you go back and look at prevalence per 100,000 population, the same pattern you see for Gauteng province, that it remains high per 100,000 population. And for Mpumalanga, it looks like the people that are exposed to hepatitis C viruses are increasing. But for Limpopo province, even though it had a higher laboratory positivity rate, when you look at the population that are infected, it was comparable with other provinces, such as KwaZulu-Natal, Western Cape province, Eastern Cape, and Northern Cape. And Northwest and Free State showed the low seroprevalence per 100,000 population. We also looked at the age groups. The age groups for this surveillance, what we found out, it was the seroprevalence was high in 20 to 29 and 30 to 39 year olds. And the same pattern we saw when we look at the provinces, the prevalence in provinces looks similar to when we're looking at the years, so I didn't include this slide for this one. And we went further to look at the laboratory testing patterns, and the laboratory testing patterns showed that more than 80% of the people who were positive with antibody test were not really, we are not sure if they were really followed up with nucleic acid test, as we could not link them to any of the nucleic acid test, and above 8% of the classified cases were from the antibody positive test were having a current infection. And the last section there, it is the number of people that were either treated or resolved on their own. And the circulating genotypes that we saw is genotype 1 to 5. And in 2019, the data that we extracted also showed us that there was genotype 7A, which was detected in Western Cape from Cape Town. So looking at the data, we believe, or the other thing that we saw, it shows that laboratory, basically, people are followed up in met areas, which are found in Gauteng province, Western Cape, KwaZulu-Natal, and Eastern Cape. And only few people were followed up with a nucleic acid or viral load test in any other province. And the genotype that we found, majority of them were following the same pattern of the nucleic acid test, as those are the places where they are really testing. And the nucleic acid testing in South Africa, we think it might have been affected by the limitation of NHLS laboratory testing, as mostly they are tested in tertiary hospitals, and the lack of universal HCV treatment, because maybe majority of doctors, they don't know what to do with those patients, and the lack of treatment centers in other provinces. And in conclusion, we believe that if we continue with the hepatitis surveillance information, this can be a useful tool to monitor HCV prevalence and testing patterns, improve HCV policy and guideline for laboratory and patients management, and increase awareness of the healthcare workers and community, and use this genotype surveillance to monitor if we can get drug resistance when we just the baseline for drug resistance when the universal treatment is introduced. Thanks. I acknowledge the NHLS Central Data Warehouse for assisting with the preparation of these tables, as this data was just from all medical records. We had to restructure the tables to be able to be analyzed. Okay, thank you.